All right. So welcome everyone to our October Health Councils talk. And so hope you are all enjoying the weather today. As Ken mentioned, it's beautiful where he's at. So I hope it's as beautiful where everyone else is today. So today we have a presenter, and I'll go ahead and introduce Mr. Chino and give him an opportunity as well to introduce himself. But before we do that, I just wanted, for those who may be new to Health Councils Talk, essentially we host, the Alliance will host 2 Health Council talks a month, and we'll bring in statewide resources, presenters, and essentially give them time and space, to have a presentation, answer questions, and yeah, I guess this is our way of, doing resource sharing, statewide with health councils. So I'll go ahead and kick us off with our presenter now. His name is Mr. Jeremy Chino, and he is with the Department of Veterans Affairs Community-Based Intervention. And so he's their Community Engagement Partnership Coordinator. And today he is going to talk about community-based interventions addressing suicide prevention efforts. And I'm going to go ahead and read his bio so you kind of get a little bit of his history here. So he's a federal employee for close to 30 years, serving in the U.S. Marine Corps, the Indian Health Service, and present with the Department of Veterans Affairs. The span of time has allowed him to work with adolescents in a regional treatment center and veterans for the VA Homeless Veterans Program. His current duties are connecting with communities statewide and assisting with local suicide prevention efforts focused on the population of the service members, veterans, and their families. And so I had the pleasure to meet with Mr. Chino a few weeks back, and felt like this information was important as we also work on our CHIP action plans, but also in our work, our current work with health councils and in the populations that we trying to engage. I think veterans populations very important as well. So I'll go ahead and give it to you now, Mr. Chino, and would you like me to share the slide deck, or will you share it on your end?
Again, probably like the last time. I'll leave it to you, because if I touch buttons, might just cancel everything out.
Awesome. Will do. I'll put it on this on the screen here.
Okay. It's one of those this is one of those moments where I have to allow myself to let others be in control. That's that's growth from a veteran's perspective, and that's growth in how the VA likes to view the recovery aspect. So I open with that. But overall, again, thank you for the invite. Thank you for allowing me the time to present. The material that I'm going to present today definitely is the new promotion to really get the VA out into the communities, share the information, build the communities, build or support ongoing efforts with suicide prevention. So backing up, again, I'm with the Department of Veteran Affairs, Office of Mental Health, Suicide Prevention Outreach. Previously, I did work with the Homeless Veteran Program. So I spent time, about 7 years with the Homeless Veteran, and now in this current position. And that position, and plus the history of my time with the Indian Health Service for about 18 years really helped me bring to the table a lot of the experience of what I've seen, heard, been around, traveled, things of that nature. And now in this position, it really creates that, or the opportunity is there for me to really focus on the veteran population, active duty service members, those that are in uniform still, and then the families. So those 3 demographics is really my focus area when I travel. Okay, so there's my first slide, my introductory slide. Next one. This one here, I just wanted to gauge real quick. I can't see everybody's hand, but if you just chime in, and if you're familiar with these clinics, let me know. Just raise your hand or say yes or no.
I don't see any hands up.
Okay, that's fine. That's fine. Okay, so I opened up with this: the Department of Veteran Care. They're in the Department of Veteran Affairs locations because when we say the VA, and when I hear from others when they recognize the VA, for one, they have to understand what the VA is: the Veterans Affairs Medical Center or Healthcare System, which is Albuquerque, and then to let them know even more that these are satellite clinics, the community-based outpatient clinics that are scattered throughout the state. So up there is just a snapshot of different locations. So the point is, it's not the VA is just not the Albuquerque location. We have those satellite offices. Okay. And for me to let communities know, by connecting with the local or the nearest VA location allows them to begin that open door or engage with the VA healthcare system just by visiting the local outpatient clinic. So that's a good way to get things started. The enrollment and eligibility, get their healthcare providers, appointments, and really if you identify where the closest outpatient clinic is, it tends to make it a lot easier. Travel distance, time, things of that nature. Next one. Now this one here is it shows the Department of Veterans Service locations. Now I mentioned this one because generally when we say veteran stuff, or when it's mentioned about veterans benefits or healthcare, Department of Veteran Services from the state often gets mixed up or gets confused with the VA. And you might hear this a lot from the community members or family members, veterans themselves, like, well, I went to some place for the veterans and they helped me with X, Y, or Z. And when you dig a little further, you come to find out, well, that's probably not the office you were supposed to go to, or that's not the one that is going to handle what you're asking for. Okay, so I mentioned that because by not knowing exactly where to go, who to see, leads to confusion. It just becomes overwhelming and really becomes frustrating after a while. So that tends to push away a lot of the return visitors, or that pushes away those that are actually seeking care for, for whatever their needs are. So I wanted to point that out. There's the VA Healthcare System Albuquerque, and under Albuquerque is that first slide with all the satellite clinics, and then New Mexico Department of Veteran Services, also scattered throughout the state. In the state veteran service officers are the veteran service officer and representatives. Those are the folks that can help with benefits, applications, claims, a lot of the administrative paperwork. So they're not really geared up for medical stuff. Again, like the VA clinics, they're more geared for the clinic, medical care, that sort of thing. So there's that big distinction. And I want to clear that up front because, again, hopefully as we go through these slides and the material I present, you'll start seeing what falls in the VA world, what falls in the New Mexico Department of Veteran Services world. Two distinct, two separate, but I'll add some services tend to overlap at times. Okay, so again, there's another way of having to clarify when veterans and service members, even their families, are looking for that answer, looking for that information. Next one. Just an overview of what the slides will present on here. Public health issues, some data, some strategies, my position as a community-based intervention, and then goes into detail a little more about the community engagement and partnerships program. And the last slides, a number of slides with resources. Next one. As we go through this, next one, as we go through this, by all means, if you have a question, stop me. I can elaborate, expand on it. I definitely really want to do more than just give a presentation. I want to answer some questions. All right, so again, here's the national public health issue regarding suicide. Again, because the VA healthcare system, VA affairs, or the Department of Veteran Affairs is really ramping up their efforts to engage with those populations that are still seeking mental health services, that are seeking services or resources to prevent suicide. And again, this is where my program comes in. Having the VA travel and really plug into communities. And that's really a big promotion for this year. Whereas before it was more like the come to the VA, go to the VA. It's always taking that individual from their area and having them travel to this, travel to the VA where time and distance can be a factor. So again, the refocus now is, hey, bring the VA out to them, and that's where I come in. Help communities establish some collaborative or build ongoing efforts through coalitions or the health councils, or just something that can help support efforts. With the council here, I'm not again just really our first introductory. I'm not too sure how robust your connection to suicide preventions are, but if you can use the VA in some way, by all means, reach out to me. Next slide. This one here just gives a quick snapshot of some of the unique experiences from the VA. I'm sorry, correction, from the veterans perspective, the veterans world. Some of these you'll see overlap into a civilian counterpart. Those that have not served in service or spent time in uniform, there's always going to be some financial economic disparities, maybe some homelessness, overall health and well-being, and just their social connections. I'm sorry. But here's really where it stands out for the veterans' unique experience is that second point there, the service connection. It reads, VHA patients with military service-connected disability status may have a lower risk of suicide than other VHA patients. Because of the experiences that are lived while they're in service, all the traumatic events, danger, just high risk, trauma, those environmental exposures, that's some of that unique experience that a veteran service member goes through, and if not taken care of properly, returns back to their civilian world, civilian life, still carrying a lot of that. I call it baggage, but just carrying a lot of that experience with them. They really haven't begun to process it out. So the service connection there is a big part, because if a veteran can connect with another veteran or another service member, they share that common background. They share that same speak, that same way of viewing viewing a traumatic event. Say it's an explosion, all right, where bodies were hurt, there's life that was taken, and they can see that, or they've seen it together, and they can relate to that and talk about it. And so that's where that connection really helps with at least from the veteran side of it, is to connect with someone else that's been there, seen it, done it, lived through it, and that's that bond that's formed, and that's that bond that still continues, and veterans look for that. They try to continue that bond after they left service, and strangely enough, they can't find that same type of bond from their friends back home, even their families from back home. Okay, so that's where that struggle is. So that just shows, again, unique experiences from the veteran world. Next one. Some data information here. At the time of this slide presentation I was put together, you're going to read some statistics. You're going to read some data here that it was presented at the time, and information was gathered from even 2018, 19, and 20, even 2013. Okay, so in the last 2-3 years, the VA is always presenting, updating new information, new statistics, new data regarding not just suicide prevention, but just overall healthcare, access to resources. The VA really pushes out a lot of information. So if you see something here that doesn't quite jive with what's current, like I said, it at the time this slide presentation was put together, this is the numbers I had to work with here. But you'll see from between 2020 and 2019, fewer suicide deaths from veterans. The decrease, it fell by 9.7%. And the way it looks now, it's going on a downward slope, which is, which is a good thing. Next one. Some other information here regarding data. In 2020, that slide reads a little over 6,000. The average, we've heard that average just, in general speak, where the term of 22 a day tends to be the go-to number. But that's not to say that could have gone up or gone down. So again, depending on when this information was collected, that's the number that was given. 6.8 is the average number of veteran suicides per day. Again, the suicide rate, a little over 31 per 100,000. So for those that really like numbers and data, take a look at it, because again, this is what I've had right now. They haven't updated my slides yet, so I'm not sure what the numbers will read with the new information. Next slide. This one here shows suicide deaths, the methods involved. Now this one covers a span of 2001 to 2000, or I'm sorry, yeah, 2020. So span of 20 years, more or less. It shows the changes. It shows the rates between veterans and non-veterans, between male veterans, male non-veterans, women veterans, and women non-veterans. And the types of methods: firearms, poisoning, suffocation, and other. Now, for the most part, firearms is going to be at the top of the list. And there's various reasons why it is, but this one shows firearms is the highest. Question asked, are poisoning taken in overdoses? So I'm guessing that's the overdosing. I wouldn't have that information with me right now. But if you would like that new information and any information regarding overdoses, I can present that to Ms. Antonio. But again, if you just look again on these statistics here. Next one. All right, so here comes the prevention health strategy. Here's how the VA looks at the strategy for suicide prevention efforts. The VA's public health strategy combines partnerships with communities. So those bubbles there you have on the far left, the community-based plus clinically based equals the full public health model. This might be something common in your back area, your backwoods, or from your backyards there. Really having that public health approach and jumping in, boots on the ground, grassroots stuff, really plugging into what's in the community there. Question asked here is, do you have information on the Memorandum of Understanding with IHS? I'm going to say yes, but there might have been some amendments or some new information to that. I've heard some discussion about it, and I don't know yet if the new information has been updated across the board with IHS. So that's kind of a general response to your question, but again, I don't want to get too far in the weeds on that one. That's not at my level to speak on, but I can find that information that is current. So that's two things I gotta get back to you. Data and MOU. Okay. Okay, so that's the public health approach in the VA. Next question, or next slide. So the VA Suicide Prevention 2.0 vision is this: community-based prevention strategies and matching that up with clinically based interventions. Okay, so it's those two. Not only is it just you take care of your own community, guys, and we'll leave you be. It's now, hey, you, by taking care of your own community, we'll also include the VA's clinical side of the house to support your efforts, to bring in support, resources, material, whatever that community is asking for or is needing, that's where the VA can that the VA can now come in and provide that support to that community. Let me ask, I can answer that question that you mentioned or that you asked there, Kenneth, about can a veteran go to any IHS clinic? That part is yes. That's always going to be a yes. Also, they can go into any clinical within the community and have those services provided then and there, and then in turn have those services, if they're eligible, if the veterans are eligible for certain services, the VA will reimburse that clinic or reimburse or take care of the reimbursement. That information comes out of the new Compact Act. Again, where the veteran is in need of some medical service and they're miles away from a VA clinic or a VA hospital, if they just have a smaller clinic or a medical center nearby, they can travel there, get their services taken care of, and again, have a VA provide reimbursement. I hope that answered your question, because I know that one is a yes, that veterans can stop into any clinic now. Okay, so this, again, back to this slide here, the Community Engagement Partnership Coordinator, which is yours truly here. This is where I can start help bring in some of that information to the communities and help them or provide extra information or just whatever the help it looks like in that community. I can offer suggestions. Again, this one gives some 3 examples there under the community-based prevention strategies. Some of these strategies come out of the higher level that I work for. Is the Veterans Integrated Service Network. I mean, that's where a lot of the information starts from. It generates and it comes down and it comes down and it comes down to me. So I take that information and share that with different communities. Okay. The second one there is that Together with Veterans, that is another type of program that works, that is veteran specific, I guess, veteran specific for veterans helping veterans. That is a national program, from my understanding, that can help also, again, plug into different communities and work with that community to start building up, you know, a collaborative, building up the infrastructure so that the community becomes somewhat self-sustaining to manage and care for their own community of veterans, the service members, their families. Okay. That last one there is the Governor's Mayor Challenge. That's statewide. That's a statewide initiative. Okay. Regarding suicide prevention. So those are just 3 examples of some of the resources, some of that help that is out there to connect with different communities. And again, on the other side is the clinically based interventions. That's like standard VA resources. The CBT work, DBT work, PTSD work, substance abuse work, those programs that already exist in the VA. That's where the VA clinical side of the house can now match up and help support smaller communities. Next one. This one just shows and says suicide prevention is everyone's business. Oddly enough, when I mention this to communities, some of the initial response is, well, I'm not trained, or how do I help someone? So again, some of that can go back to the training that the VA or myself can come out to the community and provide, or just share types of interventions. But here's why I let folks know is even for the general audience to hear a presentation or to know where the clinics are or to know where veterans live, by them listening, by that audience listening to this information, or at least picking up a brochure, any brochure that has VA material on it, that in itself is a way to help the veteran. That is in a way to help the veteran, their families, or service members. Because now, even today, with me sharing this with you, my thinking is you'll have a little more knowledge to say, hey, I listened to this presentation, and guess what? There's clinics. There's VA clinics throughout the state. There's veteran services offices throughout the state. There's this guy, his name's Jeremy Chino, who's a community engagement coordinator. He can come out to your community and present. He can share, train, provide resource. So again, I'm thinking that might be the takeaway after today's presentation. So going back to this slide again, it's everyone's business. Okay, because again, it either impacts a family or the person or the community directly. It can affect them directly at different levels of intensity, but someone's going to feel something out of that ripple effect. Next one. Okay, so here comes my meat and potatoes here. Suicide Prevention 2.0. Again, that's the VA's newest version of really promoting community-based interventions. Basically having me go out to communities now and connect with them. Next one. Some of our work is mashed up with the CDC, SAMHSA. This slide gives information about the CDC's preventing suicide technical package. Okay, if you look there, you're going to see some of that will be captured by the VA's suicide prevention package. Okay, next one. So here we go. This is the VA's version of it. These are the focus priority areas across the board for what I do meeting with communities. That first priority is identifying service members, identifying veterans, identifying their families. And once you've identified them, screening for suicide risk. For some, this sounds simple, like, oh yeah, just identify who's a veteran. Oh yeah, he's a veteran. My uncle's a veteran. I know a friend who's a veteran. They served in time, or they served their time, or they're still on active duty. Those are the good ones. Those tend to be the easy ones to identify. Or you might notice them because they're wearing a cap, a T-shirt, or they're always marching during the 4th of July parade. Okay, so again, those are the easy ones. But there's also a population out there, or there's a percentage out there that does not identify as a veteran or prior service. For whatever reason, sometimes it's mental health issues, sometimes it's the shame, the stigma, just that negative feeling of being in service and carrying that negative feeling when they leave service. I don't want to identify anymore. I don't want to be a vet. I don't ever want to say I was in the service. Okay, so those are those reasons, whatever they are, but that's that percentage that we're also looking for, that we have to really go out and find them. Okay, so that's part of it. The other part is sometimes veterans or their family members or someone will come in to an office, to a clinic, to some program, and when someone in the office is doing a screening, right, the intake screening, name, number, where you live, address, sometimes that they're overlooking the information of, they're looking at information if that person has served in uniform. Okay, so part of that is another campaign from the VA is what it's called Ask the Question. So ask the question is, have you ever served in uniform? Okay, because what can happen is once that box is checked or they identify, yes, I've served, that in itself can open the door immediately to the VA healthcare system or to VA system for healthcare, for benefits, maybe for burial services. That can happen a lot faster doing it that way versus going through the screening and then eventually later on down the way, oh hey, 5 years later or 5 months later, yeah, I'm a veteran, I'm in service. So it just delayed, or it just extended that period of time where they could have received maybe some benefits or eligible for some programs. So that's one of those campaigns that the VA is really encouraging providers, programs, offices, ask that question. And then once you ask a question and it's identified as yes, I serve, contact the VA, or again, through me, we can open up a direct line of getting them established in the healthcare system. The second part of that is the suicide risk. Are you screening for suicide risk? And if so, what else can the VA support that program with? If you're not screening for suicide risk, hopefully somewhere in the program's intake system, they're able to identify this one has some ongoing healthcare issues. Their well-being is kind of off. Maybe we need to really get them connected with the VA or get them with someone who has that specialized care. So all that goes back to that screening and identifying. So that was the first priority. Second, the priority is promote connectedness and improve care transitions. This second priority, when I mentioned early on about the veteran connecting with veteran, that is one way of promoting connectedness. Get those veterans or those service members connected with a support group, or get them connected with some place or something that helps them work through or work on or just overall improve their well-being. The same goes for families. Okay, again, families that have been caregivers that have seen all the ups and downs of their veteran returning back home, the families also need that support. So again, there's family programs out there that are just geared directly for them. And I have a few examples. I have a few contacts about that, and I can share later on. So part of that is that part of the improved care transition is, again, when you find those veteran service members that are on the fringes or just on the outskirts of town, or you rarely see them, but they're out there. The VA is not going to be everywhere all at once to see them and encourage them to get into care. So again, this kind of comes back to that community involvement, that community intervention, and say, hey, Johnny, I see you out in the woods quite often. How about we sit down and just, let's talk about, the sunshine, stars, and just talk about whatever. And then at some point you're working that rapport with them, that trust building, and all of a sudden, hey, well, tell you what, how about we call the VA, or how about we go to the clinic? How about I drive you down there? Let's get you established, or let's get you connected, or at least I can drive you and have you talk to someone at the VA that might be able to answer the questions you probably need answers to. So again, it's proven that care transition versus, hey, you're a veteran, Johnny. Well, tell you what, why don't you just go to the VA? Again, that's kind of what we're backing away from. We're really wanting to be out in the community and help them kind of care for their veteran population. So that's the second priority. The third priority the VA is promoting is increasing lethal means safety and safety planning. Going back to that slide of firearms being at the top of the list, not only is that not only does the firearms fall into the culture of the military world, but that's the culture, I believe, in New Mexico. Hunters, right? Sportsmen, firearms enthusiasts. Firearms are going to be probably just to the left and right of you. So one way, or one of the ways the VA is really promoting, is lethal means safety. Those can be in the form of gun locks, cable gun locks. Those can be in the form of storing medication behind a locked box, or it's just finding some way that doesn't make it easy or simple enough for a veteran who's going through a crisis or going through some type of trauma, flashbacks, or just not feeling right about themselves. It slows down that thinking, or slows down that action between the thought and the action itself. Okay, so that's really where the VA is really wanting to promote lethal means safety. Lock it, put it in a box, have a friend care for it, or just finding some unique way that's going to prevent the easy access to it. And the second part of that is safety planning. From the VA, man, we're big about this safety planning, and it's real simple, and it looks different depending on providers or different programs that provide safety planning. Well, when you feel like this, or when you're thinking this, what are the responses? What are the better responses? Where are those safe places to go to? Where are those people that you can trust? What happens, or what needs to go? What needs to go in front of you, so that way when you're in a crisis, you know, you're going towards a safe place. Again, those safety plans are unique to individuals. They know what trips them up. They know where they get their strength from. So they're unique to each individual, and they're personalized. So again, those three priorities are what the VA is promoting. Identify service members, veterans, and their families, screen for suicide risk. Second priority is promote connectedness and improve transitions of care, and increase lethal means safety and safety planning. Next one. Okay. Again, some of the same information from the CDC. So the priority is the VA and the CDC are complementary. They mirror one another. This slide here shows my my community-based intervention work. On the far right in the blue shaded area box, again, I gave those three examples of the Governor's Challenge is one program that can help with suicide prevention. Together with veterans is an example of that connectedness, connecting veterans together, connecting service members together, even connecting families with other families together. And then the community engagement partnership for suicide prevention, that again, that's where my bread and butter lies. A lot of it involves outreach. I'm traveling around. I'm connecting with different communities throughout the states. Sometimes it's good for me when I'm out there, because if I know what's working or what's happening in Albuquerque, I can share that with Las Cruces, vice versa, or just bouncing information across. Or I'll take a program's brochure, and as I travel, I'll mention it. And sometimes the receiving end says, "Oh, hey, I know about them," or can I know more about that information so that we can use that information in our community? One example that comes to mind is Paws and Stripes. It's generally known for a program that provides service dog training and service dogs to veterans with PTSD or some mental health issue or medical issue. But that's not only what they provide. Underneath that Paws and Stripes umbrella is the healthcare, mental health care, counseling, therapy. Some of that is the connecting veterans with veterans, again, support groups that the veterans have for them to share and connect with other veterans. So again, I like that I can travel, because I'll take information from one place to another, and it just builds the network. Next one. Again, I just show some of the information regarding suicide prevention examples. Next one. This one gives a little more information about the Governor's Challenge. In the time I've been working with Governor's Challenge, or being involved with Governor's Challenge, it's growing in the way of including other agencies, bringing other agencies to the table, so that, again, the network building, the foundation building, everyone has shared their information together. And I say that because not everybody has the same information, right? Or the same tools, or even the same toys. Based on the grant information, based on rules and policies, based on the law, just based on financial support within that program, not everyone's going to have that same thing. Okay, so again, by bringing people to the table like Governor's Challenge, Department of Health is there, New Mexico Department of Veterans Services is at the table, the VA is at the table, tribal coalitions are at the table. I think the New Mexico Suicide Prevention Coordinator is at the table. So again, we're all sharing that information, seeing what works, see how we can support the Governor's Challenge, take from it what's needed, leave what's needed, and just share, building networks. Next one. So actually, even I'll even use the Health Council here. After today, and what I've been doing, again, is taking the information and say, hey, I know this person, Miss Antonio, because we contacted before. She's part of the health council, and I believe this is what they're doing. They're plugging in with maybe with the tribal populations. They're working on bettering the community, so I can take that information and share it at my next visit, or at least I have it in my back pocket to bring up when I can bring it up. More about the governor's challenge. Next one. Again, together with the veterans is another example of a program. How many of you are familiar with a place called Ford Flag? Well, Ford Flag is a local Albuquerque Veterans Wellness Center located in Albuquerque, right off Central and San Mateo. If you happen to see a big RV, like a, I don't know, 30-foot RV, that's their mobile advertising board. And they too are focused on suicide prevention efforts. And what's good about them is that they travel as well. They travel all over the state. They drive out, even in the rural communities, they drive out, set up, stay for a day or two, and they're just, sharing information. Yes, Ford Flag. And I'll provide information at the end. But again, that's one of those unknown gems out there, because man, they're all about veteran stuff. They work with the VA. I work with them. They're part of a coalition that started up in Albuquerque. So again, it's another way of having an access to a resource, even for maybe your employee get together days, right? Your barbecue and bring everybody out. Ask the Ford Flag to come out, set up shop, and just be there and be present and ask those questions that need to be asked. Okay, so that's an example. Ford Flag is an example. Wounded Warriors, if you've heard of them, that's another example. And there's many others, national programs across the country. There's some programs that are based out of Albuquerque that are homegrown. And those are the ones I like working with, because I can work directly with them and help provide them information and resources, material, etc. Next one. Okay, so my work here, the Community Engagement Partnership Program, we serve as subject matter experts in public health approaches. I use that term lightly. I'm still learning. And there's a lot of knowledge, a lot of information out there. But I do know where the VA website is located and where I can direct people, or where I can pull the information. So that's open information hidden in the VA website, the va.gov website. Scroll through it, make yourself familiar, see what's in there. We also help with coalition development and facilitation. Again, coming out, training, providing material, presenting, answering questions, providing names and numbers. Let's see. We work collaboratively and facilitate with communities, develop, strengthen evidence-based practices. Right now, I mean, over across the country, we have about 800 community coalitions, and we're still building. And that's part of my job, is build and establish and recognize coalitions throughout the state. So got one set up in Albuquerque. It's still brand new, so we're working on that. Gallup has one that we started up. And I tie in also with the Las Cruces Suicide Prevention Task Force. I tie in with the United Prevention Coalition. And there's a few others I'm working on. So again, that's where I like to share that network that builds. I'm involved with you right now presenting, and I can use the information you share with me to pass along and distribute where I go. So again, really, it's networking, building foundations, establishing coalitions. Let's see, from Catherine. Oh, by all means, yes. Count me in. I will be there. I love to travel, love to speak, and really get that information out there. And I say that not, I say that more because I think live and in person, is a plus because, man, I really get animated, and you're starting to see me get animated because, man, when I start talking VA stuff and VA veteran families, oh yeah, you'll see me come to life. So I'm trying to keep myself composed here. So by all means, yeah, I can come and travel and present. Next slide. All right. Some more about the program here. Another segment of the community engagement program or the partnership program is a CEPC work, which is the Community Engagement Partnership Coordinator, which is me. I also am able to tie in directly and partner up, team up with my suicide prevention coordinator and her team out of the Albuquerque VA Medical Center. So again, that's a direct link for some communities to know and to have and recognize we have a direct link to the suicide prevention program coordinator. Their team of social workers, their team of psychologists, licensed clinical social workers, covering substance abuse, mental health, you name it. Okay. Sometimes they can help with answering other questions about the VA medical system. But again, unless programs or communities have an established suicide prevention coordinator, this is what they're missing out on. Okay, so as I do my work connecting, I can sell that program and say, hey, you got someone there. And the more we stay in contact, we partner up, we collaborate, the more you're able to access the VA world for medical care, for health care, for dental care, for homeless veterans, housing, occupational therapy, compensated work therapy. I mean, just whatever the VA can provide. That's the way I can help them understand more than just telling them to go to the VA or get on the website. That's why I like coming out in person. Next one. Just an overview of my work as a coordinator. And it shows in those bubbles there to enhance and expand efforts in the communities. I'm part of the local suicide prevention team. My role is non-clinical. I mean, just by my profession, I'm not a clinician, but I can answer some stuff based on what I've gone through, my experience, plus just what I do for the VA. Okay. And I say that because sometimes in communities that I present to, I find that question that is just lingering, that has to be asked, but it's never asked because it's more uh, uh people tell me, well, I didn't know if I should ask it, but the question usually comes up like, what happens when someone is in a crisis? How do you handle that? So it's real those personal, in-depth questions, and it's usually because that person that asked the question, it's my family member, or it's my uncle that I'm taking care of, or it's my son that came back. How do I do this? How do I work with them? What is there for them? And I for me, I cringe when someone responds with, well, you should just go to VA or go see a doctor. To me, no, that's not it. That's not it always, right? Sometimes the response and the intervention is, hey, just being able to talk to them, learning how to listen actively. And for one, listen actively, but listen with intent, because you want to listen, you want to hear them out. And I find that kind of builds the rapport, that opens it up a little more. Okay. And that's those little nuggets that aren't always told in a presentation or in a conference or on some PowerPoint. I like being that, I guess, that person to really personalize it. Ask me that question, because chances are I probably went through that, and here's how I responded, or here's what I remember about it. So that's why it's good to have that in my back pocket, because when I'm in the communities, I can guess, and it's probably a good guess, that what they're responding to or what they're asking about is what I've gone through, and I'm able to connect with them on that level, share with them. Some more information about the overview: educate on suicide prevention, coalition building, and public health planning. Some stuff is probably in process in the communities, based on what I know about maybe their clinics, their mental health clinics, their clinicians, their therapists, their counselors. just whatever provider is available in that community. And that's good. That's a starting point. And it's always good to add a little bit more that'll support them. Okay. Because that one provider, I'm guessing, is probably getting burned out. Those crisis moments that the police are getting called for, those tend to be more than enough. Okay. So again, if certain programs or certain interventions can be implemented that are at the lower end before a crisis escalates, if they can be implemented early on, the better outcome it is. Because if I can address a fire early on, maintain it, keep it under wraps, the better it is, so it doesn't explode into a wildfire. That's the best visual I can give. Next one. Again, some of the roles I have: collaborating, providing leadership, disseminating program, evaluation, and surveillance data. That's for down the way stuff. Once I'm ingrained and interwoven with a community, oh yeah, I can really get intense, but it's good because the more information comes in and how to set up programs, how to set up evaluations, how to look out for those certain issues and concerns, challenges, and barriers. Next one. Some more about the technical assistance, different tools I can bring out, what we call toolkits, different toolkits for different issues or concerns, like suicide prevention, like compensated work therapy, PTSD, violence or intimate partner violence prevention. So we label them as toolkits, and inside that toolkit is usually another layer of resources, hyperlinks, handouts, promotional items. So it kind of varies, again, depending on what the community is asking for. Different trainings, I can connect you with different websites that provide veteran or military specific training about the military veteran culture, peer support work, just, it varies again. Different technical assistance and quality assurance. I mean, that's for down the way stuff. Okay. I'll leave there. Next one. So here's what the expected outcome is after all the work we're doing together, is that the partnership leads to better outcomes. Partnerships promoted by healthcare organizations with communities have been shown to improve patient outcomes. That's a long read, and I'm going to leave these slides with Ms. Antonio, so you're free to distribute them as needed. So review it at your leisure, but really the expected outcome is to increase the suicide prevention efforts, thereby reducing the suicide statistics and basically just reducing suicides, period. Okay, so the more work that is done, the interaction, the involvement between the VA and my position as the engagement coordinator with communities, I think it can only strengthen whatever is happening in that community, or bring in a new material, bring in a fresh voice, bringing in a new vision, or just whatever. Next one. So I don't understand. Some other examples of partnerships. I mentioned the Governor's Challenge, Psych Armor. That's in the resource in the end slides, but Psych Armor is a good resource to really look into. It provides different courses and classes about the military, veteran culture, veteran experience. Some of them can be taken for CEUs, for those that need those CEUs for certifications, licensure, whatnot. Suicide Prevention Month. The VA, every September is a suicide prevention month from the VA. And my schedule was filled pretty much. I was just bouncing around, providing, presenting, sharing information, traveling around. So although that's designated for month of September, every year round, daily, we're out there preventing, or not preventing, but we're out there sharing information for the suicide prevention effort. Okay, so anytime, email me, call me, request a presentation or anything that you need from the VA. It's throughout the year. Firearms, sporting arms. Again, I mentioned that as part of those lethal safety safety planning. Okay, next one. So for effective community-based suicide prevention and for successful coalition building, it is important that all members actively participate in these 7 areas here. Sharing and developing a vision, identifying needs assessment, organizing, planning, implementing strategies, evaluating what's working, what's not, and sustainability, how to keep it up and running, how to keep that collaborative, that team up and running. Number 5 there says implementation. And I look at that as the non-cookie cutter approach. Okay, again, what works for one community is not going to easily translate to another community. More so for the individual veteran or the service member or the family, what works for one, it's not going to be the same for the other. So I always like to say, have a buffet menu of sorts, have that robust wraparound service that your program can allow or will allow and can sustain. Because sometimes, again, depending on the infrastructure of a community, they're not always going to have the financial means or resources to start up some cool program, right? That's going to require lots of dollars to maintain it. I always just encourage even the simplest, the coffee get-togethers with a veteran, with their families, those community yearly events that happen throughout those communities, right? For parades or seasonal stuff, seasonal events, or just holiday events. Those are probably those better ones to use and expand on. So that the one way is including the veteran specific population, the service members, acknowledging them, even just a simple letter writing campaign. I always like those kids in elementary school, right? If you remember these, when it came time for 4th of July or Veterans Day or just something, I remember all these letters received from elementary kids. Dear soldier or whatever, thank you for this, wish you Merry Christmas. So even those were like, man, those were a boost to morale. Those are those ways of just inexpensive ways of connecting, building connection, building that support. So it's not always the cool multi-million-dollar, $1,000 programs. It's just something simple, right? So that's why I come back to that number 5, the implementation. Whatever you design for that community, implement it. And it has to be relatable, right? It has to be relatable, has to be easy, simple enough for individuals to engage with and stay engaged with. Next question or next slide. Again, always measurements for me here and for the community. What are your short-term objectives, your intermediate, and the impact it has? On the left hand there are short terms. Of course, enhance suicide prevention networks. And that's what I do. That's what we do with communities. Build support, network, build foundations, grow it, develop it. Reduce gaps in community-based suicide prevention systems. Again, that's where the implementation comes in. Not everything's going to work. And I'll say it, not everything in the VA is going to work in that community. However, in the community, there's probably something already established. Like I said, the parades, the holidays. Sometimes it's those alternative methods, medicine men, the spiritual side of it, the holistic stuff, right? Some of that stuff also has to be acknowledged and implemented so that the individual has options. It's not always just going to the doctor, going to a counselor, or receiving medication, right? Those are good. They're there for that, but also have to consider the alternatives. So that's where those gaps are, reducing those gaps. Because if I can start functioning using an alternative method, at some point, maybe what will happen is then I'll start to work on over to the VA side of it. Okay. Or maybe the VA side is so heavy with programming that they can use this when they go to their communities and say, hey, this is what I learned in VA. and share that with other veterans or their families in that community. So take a look at that slide for the intermediate objectives, and again, the overall impact that's anticipated and expected. Reducing suicide deaths and attempts, reducing all-cause mortality, reducing suicide ideation. Next one. Whoa, the biggest slide of them all. Questions and answers, or questions and discussions. I know there was a few that popped up. I've answered some.
Yes.
I know I haven't answered all.
Yeah, I can answer some that you've missed if that's okay.
Sure.
And a quick time check. I know it's past 1, so yeah, we'll take some time for questions and close out. So we had a question: do you have a link where veterans can get their discharge papers?
Link. Okay. I'll share this with Miss Antonio that you're asking. But yes, there is a link that is used quite often, and it's called the National Archives. But I'll send that information with the link to Miss Antonio, and then Miss Antonio, if you would just go ahead and redisseminate it. But National Archives is a big one online. There's also the Department of Veteran Services representatives. They can help with obtaining a DD-214 discharge paperwork. And here's what I tell on that. Here's what I tell veterans and their families. Again, their families, because generally families, spouses, dependents probably have a better, clear understanding of what needs to be done at times. Because sometimes the veteran is not always going to disclose or share information. So I tell them, once you get a copy, take it down to the courthouse, put it on file, establish your record there, or leave it with a service officer. Sometimes they'll accept a copy so that it's always in their file. So if the 214 discharge paperwork is lost, misplaced, unreadable, they can go back to those places and request a copy. That simple. Other question?
I do see Randy's hand up.
Hi, how you doing? I just had a question. I read a few months ago that Stanford University is actually uh, have been doing research and studies with psychedelics.
Mm-hmm.
They actually implemented it into their emergency hospital for suicide and suicide ideation. So I was just wondering, is that something that the VA has looked at or something? I know the Army's dealt with psychedelics in the past and some weird experiments, but I mean the article that I read, it's actually pretty cool. And I say this because being Native American, I've partaken of peyote in the Native American church. So there is some credence there, I believe. But I'm just thinking, just asking if the VA has actually done something like that in a controlled situation or area, I guess, to help individuals with PTSD or suicide.
Wow. Let's see. Without getting myself fired, because yeah, that sounds like research stuff. But here's what I just pulled up when you asked that question, because under the VA banner, I'm going to read this. Yes, psychedelic medications for mental health and substance use disorder. So again, kind of when you mentioned Stanford doing some research, doing some testing, or just trying it out as an alternative therapy, I think the VA is starting to look into that, maybe broaden their view of what else can work, alternative therapies, different modalities, various models. And again, here's my take on it, and this is my 2 cents opinion, is because the VA is evidence-based medical model. They're really aware now, or the VA is aware now of possibly considering alternative therapies. I mean, but we're still big on the CBD stuff, the medical marijuana. Yeah, some stuff it's just not that easy to acknowledge and approve right away. So I'll say they're still considering it. Nothing's official that I know of, but I'm going to send this one as well because you ask, and maybe this might answer more of your question. Sound fair?
Yeah, thank you.
Okay. Oh,
I just shared the article if people
okay.
are interested. Um, you know, I guess from my point, you know, as Native people, we've been using this as medicine, and it is medicine, and it's part of the Native American Church religion, of course, in a controlled, not scientifically controlled situation or type. But I do know that you know it has had some positives from the native uh, the native view, I guess.
Right.
But just and I was actually interested to see that in mainstream when Stanford started utilizing it. And the article that I sent is actually deals with veterans.
Hmm.
Yeah, take a look at it. Thank you.
Yeah, yeah, yeah. And I sent what I just shared with you on the chat box also.
Yes, thank you, Randy. Miss Jeremy, do you have time for 2 more questions? And then we
Yeah,
can
I'm here for as long as you need me to answer some questions.
Okay. So the next question is, how can the toolkits and trainings be accessed?
Let's see. Let's see. I'll probably just send out again the hyperlinks to you. That way they're all in one page. So toolkits. If that answers your question about how to access them, I'll send a, a document to Miss Antonio, and then inside that document will be various hyperlinks for the toolkits I mentioned.
All right, thank you. And the last one here is, what are the resources available to veterans' families?
Oh gosh, that is so robust. If you can narrow it down, that might help me compile what you're asking for. But I mean, I'll say this: some resources obviously can be accessed through the internet. You just punch in the search box, veterans, military, whatever, and you'll get a whole range of it, right? So there's that option. When you narrow it down to veteran or service era or gender or type of medical issue concern, that can really break it down even more. And then that's the information I can look for to send out. But uh, you know, I don't want to be so general, just say just get on the internet. If you help me out here and find out specifically what you're asking about, I can get some. And here's the thing: I don't know if I mentioned thoroughly enough. The VA, because it's a federal, national at that level, their reach is nationwide, right? And there's different criteria, different eligibility, different programmings in that world of the VA. And then at the state level, again, because it's statewide level, there's different programs, different eligibility requirements, there's different services at that level. Sometimes they overlap, or just they're sometimes so distinct that one can't access the other. Then at the community level, there's certain resources for the veterans and families. I gave it the example of Ford Flag. And some of the veteran service organizations, like the Veterans of Foreign War, like the American Legion, Disabled American Veterans, those can operate at a community level, although they're national level, but they have offices at the community level. In Albuquerque, oh gosh, I can turn left or right in Albuquerque and I'll run into one. That's not the same for faraway communities. Sometimes they have maybe one service organization, or the next service organization is in the next county over. So again, it varies, and it's determined by geographic, or whether it's a national level, a state level, or community level. So I hope that answered some of the question.
Yes, very helpful. And the last one, all of the resources are available to any person that served for any length of time, correct?
Wow, that's one that tends to get misconstrued quite often. Let's see, how would I word this one? Hmm. Hmm. Okay, I'm gonna try to pull this one apart, because again, what I mentioned, national level, state level, community level. Yes, there is some determination based on length of service, even from day one to under 6 months. There's some services, or yeah, even for the ones that only serve maybe not their full contract term of 2 years or 4 years, there's still some services available. For example, currently right now, mental health services, mental health, suicide prevention, those services are across the board. Military sexual trauma is across the board. But again, when you get into different levels of service-connected disability, that can vary. So that service might be only afforded to someone who is totally service-connected disabled, or someone who is just maybe a lower rating. They're not going to get the same services. Okay, so there's that. Income can be a factor in it. And I use the homeless veteran program as the example. Homeless veterans, sometimes they have to go through a screening also, the intake. And when it comes to finances or financial stuff, they might exceed that threshold. Okay, so that might rule them out. Different service eras, when a veteran military service served their time, is it during World War II era, Korea, Vietnam, Desert Storm, and the latest Iraq and Afghanistan? Sometimes those eras don't have the same benefits or entitlements. Okay, so again, you got to really understand the network of services out there, because it's not always across the board. And I say that because here's what I found out in working with the homeless veteran program. Sometimes a veteran will come in and say, I'm a veteran and I deserve, I served my country. Yes, thank you, you did. Now let's do a screening and let's find out what the federal guidelines say. So when they're doing the application, they find out they're disqualified, or they're just not eligible. Okay, so again, you gotta weed it out. You gotta really understand which programs, which services, which benefits apply to that veteran. And even for veterans, dependents, spouses, and children can also have their own set of entitlements and benefits. Okay, so that question is it's a lot of moving parts, and you got to find out which one fits and which one applies. I hope that answered, because I know it can get pretty muddled up when people say, well, I'm a veteran, I serve, I should get this, and this. As let's break it down a little more. And sometimes these are based on federal guidelines determined by Congress, right? Determined by law. And just the other way that can apply is for a veteran, again, who said, they come in, they say, well, I don't know if I am entitled to any benefits because I only served maybe 1 year, and then I got out for a bad back. I broke my back, so they discharged me. I said, well, let's talk about that a little more. What happened? Well, it comes to find out, they were medically separated or medically retired because either they were on active duty and they sustained an injury that gave them total back problems. So now they can also become rated at a 100% service-connected disability, which brings an automatic compensation money just by that fact alone. Okay, or they can have a pension applied to what just different reasons. So again, it's got to understand what the veteran's asking about, what they're entitled to, what the family is entitled to, what they're unaware of. And that's the big part that's missing, because the veteran or families are not talking, or just not understanding, or they were told something even as 5 years ago. Why I tried to apply 5 years ago and I was turned down. So in that 5 years, I always let them know different laws have been upgraded. There's new laws now from the Congress that says you are now eligible. Okay, and the one that just came to light was the environmental hazards. That was really a big push from the VA, the Department of Defense, that environmental exposure, burn pits, environment, toxins, stuff like that. A veteran who was not eligible 5 years ago, they file an application within the last year, they're awarded. So those different shifts in the time, service eras, a discharge status, length of service, all that comes into play. So again, the service representatives are a good source of information for that. So I hope that answered that question.
Yep, it looks like she gave a green light for it.
I'm on a roll. Come on now, get your quarters worth.
I think that's all the questions in chat. If anyone else here on Zoom has anything, if not, we'll close out.
Okay.
Nope. Okay. Yeah, I think thanks so much for staying about 15 minutes over time with us.
No problem.
For all of our Health Council members as well. So yes, thank you so much, Mr. Chino, for your time and presenting today all the valuable information and also for your service. And so yeah, we'll go ahead and close out, and we'll be sure to share the presentation and any follow-up information with Health Councils next week.
Okay, just so I don't miss as well. Hey, oh, thank you, Kia. My passion shows. I hope so, because man, like I said, once I get going, I get going. But I wanted to come back to a question or a request that was made for a presentation elsewhere. Geraldine, would you help me find that? Who asked that request, and I can follow up with that?
Yes, we'll share it. We're gonna save the chat, so I'll go through that.
That's right. Sierra County.
Yeah, oh, with Sierra County, and then let me see if I can find the name. Actually I can't, so I'll dig through the chat after we hop off.
Sure.
All right. So yeah, thank you so much, and you all have a wonderful weekend.
Yeah, thank you, folks.
All right, thanks so much. And